providing for lipid optimisation. We're going to be recording the session. Can I just ask that people keep their cameras off? It just helps to improve the recording quality, because I know there's a number of people who intend to catch up on the recording afterwards. So our speakers today, we've got Dr. Khalib, who's joining us, and also Evan Ojo, clinical lead for CVD. And I know Evan's going to introduce Dr. Khatib for us. Also on the call, you've got myself, Helen from the Primary Care Development Nurse team, and I've got Sarah, who's assisting. For general housekeeping, if you keep your speakers on mute so that we have the best quality recording, with microphones off as well. Any questions, if you'd like to pose them in the chat, and then if there's a particular question that you want us to address, if you want to like it, then we'll do our best to do it as we go along. Could I just check, would you prefer questions at the end or as we go along, Dr. Khatib?
I don't mind if it's interactive, so if people are asking questions relevant to the slides that we're covering, happy to take them as I go along.
Okay, that's brilliant. Thank you. If there's any questions that we don't manage to cover in the session, we're following up usually with a Q&A that we can email out to everybody afterwards. But other than that, I'll hand over to Evan and to Dr. Khatib. Thank you very much.
Excellent. Thank you so much, Helen. As always, we're very appreciative of the support that we get from the primary care development nurses in facilitating these sessions. So thank you very much to Helen and Sarah and the team. Thank you very much, everyone, for logging in today. This is very much going to be Dr. Khatib's show to run, and I'm just going to be here to probably just facilitate with that question, with the questions that come through, so that we can keep the session nice and interactive. But we are very privileged to have you here with us. Dr. Rani Khatib is a consultant cardiology pharmacist with Leeds Teaching Hospitals. He's also an associate professor with the University of Leeds. I'm sure you can see on the slide front sort of all his many accolades, but among them, he's a member of the National Expert Advisory Group on Cholesterol, and is also a fellow of the Royal Pharmaceutical Society. So hopefully gives everyone an idea of the caliber of speaker we've got with us this afternoon. So without further ado, I will I'll leave it to you, Rani, to take the floor. Thank you.
Thank you so much, Evan. Thanks everybody for joining us, and thanks for the opportunity to talk about this topic, which is probably most popular and talked about. What we're going to talk about is statin intolerance, and we're going to just ask the question, why are we so fussed about statins? Well, statins are considered to be the gold standard for managing lipids. There is robust evidence for their benefits, with many randomized controlled trials showing a reduction in cardiovascular events and 10% reduction in all-cause mortality. And we seem to learn more as we use statins, that statins go beyond just lowering cholesterol. They have plaque stabilizing activity. They seem to have an anti-inflammatory activity, and they seem to inhibit thrombogenesis as well. So it seems that they do more than just lower cholesterol, and they've got definitely some kind of ability to cause good regression of atherosclerosis. For that reason, we really like our patient to be on statins the first line, for that reason that our national guidelines recommend statins as first line therapy, and also international guidelines, of course. So for that, we always try to put our patients on statins, and as a general rule, being on some statin is better than not being on any. And hence why when we drafted the national guidance for lipid management, we insisted on actually drafting a statin intolerance pathway. So if you Google statin intolerance pathway, you can get it instantly. The statin intolerance pathway brings up the NHS England nice endorsed statin intolerance pathway. When we put the pathway, and the pathway's got two sides to it, the front side and the back side, I think people usually probably would go and read the front side. But what I would suggest, actually, reading the back side of this intolerance pathway first, at least the introduction. And that's because it sets the scene for you, what we are up against, and the fact that what statin intolerance means, when do you do whatever you do in terms of CK measuring and etc. So I'm going to be flipping between the back and the front of this pathway in order to kind of show you the link of how to navigate through it while I'm covering this topic. Starting from the back of the pathway, it talks about why statins are important and that they are the cornerstone of prevention in cardiovascular disease. It talks about how statins generally in all trials, they were very well tolerated compared to placebo. And it talks about how when statins were discontinued, there was increased risk of major cardiovascular events generally. Then it defines what statin intolerance is, which is defined by NICE. There's so many definitions for it as the presence of clinically significant adverse effects that are reported by the patient and represented as an unacceptable risk to the patient or that may reduce adherence with therapy. There are other definitions talking about adverse effects that are considered to be unacceptable by the patient. And we need to accept the fact that when it comes to adverse effects, some of them might be measurable and seen, if you like, but others may not. And the only way of us knowing whether an adverse effect is being experienced is by the patient telling us about it. Therefore, we do rely on the patient on telling us this, regardless if we believe it is true or not, or associated statins or not. But my first thing I would say whenever you handle statin intolerance, tip number one, whatever the patient is telling you, is probably worth not ignoring. Actually, acknowledging it is the best way forward to tackle intolerance, and working with the patient to address the adverse effects that they perceive or have is probably the way forward. Of course, what we need to distinguish is what people might have an issue with statins is usually, is it a statin associated muscle symptoms, what we call SAMs. So it's the main, probably the most common reason why people are intolerant to statins is to do with the muscles. People report that they're having some muscle symptoms. However, not all muscle symptoms experienced while on a statin are actually statin related. So they might be just perceived as such, and we're going to talk about that later on. So there is this phenomena, which is statin associated muscle symptoms, the SAMs. And this phenomena does exist, but it doesn't necessarily mean that they are truly statin related. So you've got statin associated muscle symptoms and statin related muscle toxicity or symptoms. So you've got the SRM and the SAMs. And the reason I'm distinguishing that is because you've got two different things. You've got patients reporting that they are getting muscle symptoms when they were started on a statin. They associate it with statin, but we don't know if it's actually due to statins or not. And then we work out and explore statin-related muscle toxicity, which we're going to detail a little bit more. Now, patients do report also non-statin related musculoskeletal symptoms, so non-CRMs. That's actually reporting concerns about side effects, that of some medicines that they might be taking, but it is important to distinguish that in some cases these symptoms have nothing to do with statins and usually is related to other conditions, and hence why we need to explore differential diagnosis when we don't think it's a statin at all. I'll talk about that in more detail in a second. It is also important to remember the risk factors that increase patients from having statin-related toxicity or intolerance: female gender, elderly, frailty, patients with hypothyroidism, patients with impaired renal hepatic function, patients who have excessive alcohol intake. All these people tend to be prone to having statin-related symptoms, specifically muscle symptoms or intolerance, vitamin D deficiency, dehydration, high intensity exercise, and of course the drug interactions that we need to be watchful for. So for that reason, the first thing we explore is how true and realistic this is. And this is a meta-analysis from over 4 million people who have been taking statins, and the prevalence seems to be, and that's based on what the patient report. So it doesn't necessarily always mean that the patient genuinely, these symptoms can be associated or linked to statins, but looking what people report, you're talking about a prevalence of nearly 9%. So 9% of patients are likely to report some form of statin intolerance. And of course, this seems to be higher in specific populations. So for example, certain behaviors such as people who have high alcohol consumption would report more. People who take high dose intensity statins are more likely to report it than those who are low intensity statins or lower doses. Those who have hypothyroidism, they're probably 40% likely more to report it, and so forth. So it is difficult sometimes to pinpoint for each individual patient what is the prevalence specifically, but the idea is we need to keep that in mind when we are dealing with statin intolerance. What does the pathway say? So the pathway, now flipping the first page, the pathway is asking a question. Does the patient have new onset or worsening of muscle symptoms since starting statins? If no, then if the patient hasn't got any symptoms, musculoskeletal symptoms, then it asks you to explore statin reluctance, nocebo effect, and use a person-centered care approach, which is detailed at the back of how to deal with it. And of course, if the patient does have symptoms, musculoskeletal symptoms, and we are suspecting statin-related muscle toxicity, which tend to be usually symmetrical, it needs to be potentially weakness in large proximal muscle groups, which is worsened by exercise. And then usually it tend to happen soon when you initiate the statins rather than later, but it could happen later, of course. So the first question we need to ask ourselves, what exactly the statin intolerance is due? Is it muscle related or not muscle related? And the first thing we say is think about, if it's not muscle related, you need to understand some of the non-muscle related side effects. So the pathway at the back details all this. You don't have to, this is all on the pathway. I'm just walking you through it and detailing it. So GI disturbances, you'll see later on from our statin intolerance clinic, many patients get referred to us labeled as statin intolerant because GI disturbances. In most cases, GI disturbances tend to be transient and patients tend to do better. But it can affect 1 in 10 patients probably, but in most cases transient. The other non-muscle related statin side effects, hepatotoxicity, new onset of type 2 diabetes, people tend to be worried about that. We'll talk about that in a little bit more detail later on. Proteinuria, neurocognitive and neurosurgical impairments, which is really, as you see in the brackets there, we tried to comment to say that really there's no apparent link. The evidence for a lot of these side effects is not really there. They talk about intracranial hemorrhage, there's conflicting evidence, and most likely benefit outweigh possible harm, and so forth. So these are the list of different side effects. I know you're probably not going to come across them a lot, but the GI side effects, the probably type 2 diabetes concern might be there. And the type 2 diabetes generally, I'll detail it later on, the benefits definitely outweigh the risk, and I'll explain why in a second. The other issues related to, for example, liver enzyme, people tend to be concerned about it. The liver enzyme got elevated, especially the transaminases. Usually minor increases in transaminases can happen with statins. It's not usually a problem. We shouldn't really discontinue statins in this case. It's only if the liver enzymes are elevated more 3 times the upper limit is then that we discontinue, and we'll probably reintroduce at a lower dose and see what happens. Unless the elevation is massive, then we reconsider. So the idea is that be familiar with the non-muscle related statin side effects, because you will find that probably in our cohort of patients that we see, nearly 40% of patients who refer to our statin intolerance, they are referred with a non-muscle. And this paper here nicely went through all the different concerns, and you can have a read of it. But basically, it goes through everything that people seem to be reporting and concerned about, and elaborates on it. The dysglycemia, a new onset of diabetes, seems to be probably more prevalent in patients who probably have pre-diabetes or metabolic syndrome, and seem to be associated with full high-intensity statins. But I think I need you to imagine this: if you've got, let's say 10,000 patients who we lowered their LDL cholesterol by 1 to 2 millimoles, you're going to save nearly about over 1,000 cardiovascular events, with a risk of developing diabetes in probably 100 of those patients. Most likely those were patients who had pre-diabetes or metabolic syndrome. So you're saving 1,000 patients from having cardiovascular events such as stroke, such as MI, and at the same time you are probably risking of developing diabetes or dysglycemia, shall we say, in probably about 100 of those 10,000. 10,000 patients. So in essence, it seems to be a risk that is there, but really randomized controlled trial seems to be that's probably very, very, very low, but it seems to be more with patient pre-diabetes and metabolic syndrome, and probably they will need some kind of treatment anyway. So this is kind of one of the topics that tend to be raised often as a risk. The other thing I wanted to highlight is the nocebo effect. The nocebo effect is basically, this is a trial where they told the patients, we're going to put you on either placebo or a statin. They did not tell them whether they are on a statin or placebo. And of course, there was a no treatment arm. What is interesting is that the placebo arm experienced pretty much the same level of side effects that those on statin. And this is called the nocebo effect, basically where people, just by thinking they might be on a statin, they instantly develop symptoms. And that needs to be borne in mind when we are dealing with statin intolerance. So hence why at the back of the pathway it says, are you aware of nocebo effect and statin reluctance? Nocebo effect, I've just explained what it is. It's the negative expectations of the patient regarding a treatment, leading to reporting more negative effects, even if the prescribed is a placebo. So it's just all in the mind. The reluctance is more of an attitude of aversion to take statins, even without even taking it. And I've had those in my clinic where patients don't take a statin because of what they've heard, or because one of their relatives tried a statin and were not good. They had some side effects. So this is reluctance. And you need to approach that with chatting to the patient, understanding what their concerns are, and going through, the benefits and the likely risks, but also the fact that you're not going to leave them in it on their own. You're going to be there for them to support them, and there are many options to do. Explain what the LDL targets, why healthy lifestyle is important, what the different options available, why we're using statins in specific, and the risk factors that could lead to worsening of statins, and that's why you need to be exploring drug interactions, for example. And of course, very important to have a shared decision-making approach where you identify and agree best options and next step with the patient, but don't fire and forget. Bring the patient back, talk to them about their experience, give them a little bit of ownership that they can start and stop things, and that you are there by their side to support them. This kind of attitude that you need to deal with the patients when you're handling statin intolerance. Then after that, we're talking about muscle symptoms. What happens if you've got muscle symptoms? Well, the first thing we say is that always make sure that you check baseline thyroid and liver and renal function, because they could increase your risk of having statin-related muscle toxicity. And then if the patient does have or develop muscle-related toxicity, it is then when you measure CK. And if CK levels are 4 times the upper limit, then you probably want to investigate. and you want to look at it. The general rule is that we wouldn't usually measure CK if a person is asymptomatic, but we measure CK when patient is symptomatic, and only we pay attention to the CK levels if they're probably 3 or 4 times the upper limit. Not any CK elevation is significant, because CK could be elevated even by people exercises. So that's kind of the other thing that to keep in mind. So I just recap in here, and I'll talk about the muscle symptoms in a second. We started by trying to understand what we're up against. Are we up against muscle-related symptoms, non-muscle-related symptoms? And are we up against nocebo effect, or are we up against statin reluctance effect? And then we're delving into the muscle side effects and what the muscles mean. And basically, there are probably 6 types of gradings of statin-related muscle toxicity. It's a spectrum of myalgia to severe myopathy, and not all of it is necessarily statin induced, but some of it could be due to statin, some's not, and therefore the only way of discovering that is to de-challenge or re-challenge. But in patient reporting CRM 0, there are no muscle symptoms. Okay, they just got a little bit of CK elevation, which is not significant. We say that could happen anyway in the first 3 months. Then you're moving on to CRM 1, where patients are having muscle symptoms without really CK elevation. So that's kind of where you're probably going to de-challenge and re-challenge. It gets a little bit trickier when you start going down the CRM types when the CK levels is elevated, and it gets more serious as you go down. I have come across one patient who actually had an autoimmune mediated kind of a statin muscle toxicity, which was interesting because he was labeled as such, and they're very rare. There's probably 1 in 100,000, if not more, and those patients usually will probably no point of retrying statins. So if they've got an autoimmune mediated element, then I probably would shift towards not using probably statins at that point. I'll just go through the CK level measurements in the pathway, just so that you
I've
have
got
an
a
idea of what we're
question.
doing. Sorry, Eben, go ahead.
Sorry, I've just got one question,
Yes, go
just
ahead.
on the last slide. You know, the SRM1,
Yes.
where it says phenotype, so is the phenotype no muscle symptoms? So in terms of what the patient's presenting with, no muscle symptoms, but actually is defined by muscle symptoms without, it's just wanting to clarify that.
Oh,
in
I
terms,
see.
So do you mean muscle symptoms, but where the muscle symptoms are existing without CK elevation?
Yeah, I think this might be a typo here, actually. Yeah, the definition of CRM1 is muscle symptoms without CK elevation. Definitely, yes. So there's.
And I've got.
Yes, go ahead. Another one.
Another question then. If this is a question from Romil Mandvia. If we have a normal LFT pre-statin,
Yes.
and then abnormal LFT soon after starting statin treatment, so with your transaminase less than 3 times the upper limit of normal, is it fine to continue statin?
Yes. You'd continue and monitor.
Stop, or would you stop temporarily and reassess
No,
to
I
see
wouldn't.
if the LFTs normalize?
No, I wouldn't stop. I would continue and just recheck. So I wouldn't wait for like 6 months or 1 year recheck. I would actually, if the LFTs are getting close to the 3 times upper limit, a slight elevation, I wouldn't be so concerned. But if it's getting close to the 3 times the upper limit, but not reached it, I would continue and recheck the LFTs. I'll probably give it a week and recheck. If there is a trend, and then I can reduce the dose. At the back of the national lipid pathway, you've got a detailed description of what to do when LFTs go up. That's detailed there. So this goes hand in hand with the other pathway. So the national lipid pathway, at the back, you've got the monitoring section, and you've got the different options of what to do if LFTs get elevated.
Thank you very much.
That's okay.
I think, sorry, just following up on that, I think the person was also wanting to ask how we can, although situation is probably rare, but could we be leaving an area open where statin is mistakenly blamed for what is actually pre-existing liver disease? So how would you reconcile that?
Well, that's why we need to do baseline. So the baseline, it's really important to have a baseline to understand what we're up against generally, so that if anything goes wrong, it is not really something that was prior. And that's one of the tactics that we use to establish potential causality or association, is by looking at how did things look like before, when did things happen, did things change when I stopped the dose, increase the dose, decrease the dose. So it's really important to have probably multiple monitoring stops if we are concerned about it. I had patients who had historically elevation LFTs, and I have wanted to try them, and I tried it cautiously, even introducing it slowly at once a week. Nothing to do with muscle symptoms, it's more to do with LFTs. And then when we introduce it gradually, it has nothing to do with it. And we've done it gradually, and we just increased the monitoring frequency. So we're bringing them in like every week to just have a look how they're doing when we're increasing the dose cautiously. So there were some scenarios where we've done that, but generally speaking, the elevation tend to be not that significant. Okay. Do we carry on? Okay. So so first thing is you measure CK, and then you need to check if CK levels really less than 4 times the upper limit, and there are tolerable symptoms, no clinical concern. In most cases, things could improve. It could be nocebo effect, could be just a perceived symptoms. So probably things are going to resolve within about 6 weeks, and patient happy to continue. But if they're not, we can always try and de-challenge and re-challenge. And I always say to the patient, I never dismiss the symptoms that patient described to me. I just say, we need to check if it is due to statins or not. So let's keep a diary. We're going to stop it for the next 4 weeks. And let me know how the symptoms get better or worse. Do you get more pain, less pain? And then after that, I'd say to them, let's retry it, restart it. And I want you to tell me if the pain got worse, stayed the same, or disappeared. And we start usually on some kind of a lower dose or a different statins. But very important when we're tackling statin intolerance to work with the patient, because remember, they're the ones who are feeling those side effects, even if we don't think the association is there, but they're having this perceived or is actual symptom. What we need to be cautious about is that if CK levels are coming more than 4 times the upper limit, then we need to start here worrying. If the CK levels more than 4 times the upper limit compared to when they're reporting symptoms, then we need to stop the statin, and we need to wait for the CK to normalize. If for any time, any reason that the CK levels are hitting more than 10 times the upper limit, then we start going down the route of worrying about severe side effects, and potentially, probably we want to give a different diagnosis, such if this patient needs to be explored further, looking into some kind of autoimmune, which is very rare, or if we're going down the road of rhabdomyolysis, which I have not seen in my clinical practice, but I know they do exist in severe cases. But CK, as long as it is hovering less than 4 times the upper limit, that's come very reassuring. If it's less than 10 times the upper limit and above 4 times the upper limit, then you probably want to stop statins, wait for the CK to normalize, and then see how things go. Because if symptoms resolve and CK normalize, then that's kind of great. If they did not resolve while off statins, then you need to consider other causes. It can't be statins, because if you stop the statins and the patient still to be symptomatic, 6 weeks, 8 weeks after that, then you need to look at what causing those musculoskeletal symptoms. And then you go down the route of if the symptoms improve, then you want to go down the route of trialing different statins, etc., and different options. And this is all detailed before going to, of course, the complete different therapy. This is detailed at the back where it says adapt person-centered approach as described. Therapy with a lower dose statins preferred to no statin. That's kind of a general rule. Being on some sort of a statin is better than being on nothing. There is evidence for that. Try and apply a repetitive de-challenge approach where you stop, give a washout period, restart with a lower dose of the same statin or a different statin, switch to a different statins, use intermittent dosing, and of course, and some patients would be okay with once a week, twice a week, every other day. Usually the longer acting statins such as rosuvastatin and atorvastatin might work in non-daily regimes. Sometimes you lower the dose and you add ezetimibe or another lipid lowering therapy in order to reduce the side effects that the patient might be perceiving. It is a little bit of no kind of one size fits all. You're going to trial and work with the patient, but it's very important that you work with the patient in order to establish what is best for them and seems to work in terms of controlling the risk. So it's very important to remember what goals are we aiming for with these patients. I always say to my patients, what we're going to do here, we're going to work together. I'm here to support you. I don't feel your side effects. You feel them. You tell me, but I'm here to help you. I'll give you control. Giving patient control really makes a difference. There are different bits of the literature about that where even alternate daily dosing have worked, and like giving rosuvastatin every other day has reduced cholesterol by about 35%. Giving patient control, where we say usually start once a week, increase it to twice a week in a week time. If you don't feel better, then reduce it to once a week there. So giving them some form of control so that they don't think we're dictating them what to do, it does help. Not all statins are the same. I'll talk a little bit about this later on. You've got lipophilic, and you've got different pathways. So if somebody's unable to tolerate atorvastatin, for example, because it's lipophilic and it's primarily cleared by the liver, you can use rosuvastatin, which is more hydrophilic and cleared more by the kidneys and the liver and so forth. So what you can do, you can switch between the statins. And this is one of the main conversations I have with my patients usually, is that statins are not the same. They're one class, but they behave differently in our bodies. And this is exactly what this slide is saying. So, for example, you've got, I know we're not using many of those statins, but rosuvastatin, atorvastatin, pravastatin, probably the ones that we use most. We're not using simvastatin as much, but rosuva, atorva are the most ones because they're high intensity statins, and pravastatin we use sometimes, and I've got a case about that. They've got different bioavailability. They've got different half-lives. I mean, look, pravastatin's got a half-life of about 1 to 1.5 hours. Sorry, it's the T-max here. The half-life is a bit longer than that. The half-life of pravastatin slightly longer, but it is much less than rosuvastatin, which has got much longer half-life. And of course, the lipophilicity differs, so they probably behave differently. So pravastatin and rosuvastatin are more hydrophilic. The rest are lipophilic. The pathway of clearance is different. Some of them got active metabolites or not. So pravastatin's got a half-life of probably about 3 hours. Rosuvastatin 19 hours. Atorvastatin 14 hours. So that might differ and the dose, and therefore I always say to my patients, they're not the same. Now, if that fails and you've tried your best with these different regimens and different tactics, then the other options you have is just to go down the route of giving your patient another option. But I hope I give you a bit of a flavor. There isn't right or wrong. The idea is you can restart with a lower dose. You can change to another statin, take into account potentially something that works differently. You can offer a low or moderate dose of a higher intensity statin. And then you can give a dosing regimen that is not daily. So it's once a week, once every other day, etc. If it works and there is no recurrence of muscle symptoms, absolutely fine, and they can work on titrating it and trying to achieve the goals. If the goals are not achieved, then most likely you're going to be needing alternative therapies added. It's very important when you're working statins to be sensible on all lipid lowering therapy, where you're going with it. So if you're looking for 60% reduction to get to goal, there's no point of giving something that is going to give you 20% reduction and just rely on it, because you know you need more. So you probably need to think about what level of reduction do I need, and therefore probably thinking ahead, what's the best combination is going to give me that. So that's kind of the kind of thinking that you need to be having when you are introducing people back to statins. I'm going to give you some cases, and hopefully we can give you a little bit of real world experience with different scenarios. Have you got any burning questions before jumping into the cases, Eben? Yes, go ahead.
So there was a question around the washout period. So I think on the slides there were, some of on the slides the pathway did say 4 to 6 weeks, if depending on the CK level, but then also you've mentioned 2 weeks. So I thought it'd be good for you to clarify that for.
Yeah. So if we're dealing with a case where there isn't elevation in CK levels, and the patient seems to still experience some muscular symptoms or any other symptoms, then a 2 weeks washout period is sufficient to have no statins left to be exerting that side effect that they're perceiving or having genuinely. So I think distinguish between scenarios where there is high levels of CK and scenarios when there aren't high levels of CK. I will probably be more comfortable in using a 1 or 2 weeks or 3 weeks washout period when there is no elevation of CK levels significant. That's more than 4 times the upper limit. But in cases where there isn't CK elevation, 1 or 2 weeks washout period seems to be reasonable to actually consider. That's what my practice is.
Okay, thank you very much. And then the other question was around the incidence of sort of statin related side effects based on the intensity of the dose, or based on the dose. So are you likely to have symptoms with higher doses compared to lower doses, and whether you've got any information around that?
Yes, you are. You are likely to have more, but even at the full doses, the prevalence is low. But in the slide that I've shown about, there's so many confounding factors, if you like, that they are likely to increase or decrease your risk. That kind of slide I put at the beginning of how your lifestyle habits, your other comorbidities, your ethnicity, etc., can affect your sensitivity to these side effects and prevalence. It is very hard to pinpoint what in each scenario individual patients need to be dealt differently, but yes, sometimes a full dose 80 milligrams might cause side effects, and one option could be to reduce the dose and add, for example, another lipid lowering therapy to actually deal with that. And sometimes it's about switching to completely different statins. So yes, the answer, higher risk, but there are so many confounders as well, you see. So it's not one size fits all.
Thank you.
Sorry, let's delve into these cases now. So these are vignettes basically of examples of patients we've seen in clinic, patients that I or my team have seen. So I'm not giving you the full details about every patient because I'm just giving you the bits that you're interested in. So for example, in this patient, 78 years old, he had very strong atherosclerotic cardiovascular disease with a history of cabbage in 2014. He's got so many other complications, gout, pulmonary hypertension. And when it comes to statin tolerance, we always, when we assess patient statin tolerance, we talk to them. We're trying to understand what is the intolerance, what did they try, when did they have it, was there an association? And the reason we do that, because we want to see if it's nocebo effect or reluctance, or is it a genuine side effects that experience, and was it kind of, did it happen around the time when they had a statin, after statin? Did they have any de-challenge, re-challenge at all when they tried it? In this case, this patient trialed atorvastatin, caused him tiredness and fatigue and muscle pain. He wasn't sure if he had taken it for long enough to be certain, but was stopped by GP. So clearly, the clinician who dealt with this patient had a low threshold of labeling him as statin intolerant. So this was an easy case that I've selected for you just to show you what we've done. This was this gentleman's baseline. He's got a very high LDL of 4.1. I mean, you can see his cardiovascular risk is massive. What we did with him, very simple. I mean, he does qualify for PCSK9 inhibitors, but he wanted to trial oral medications. So we actually decided with him to try it first before going the route of any other drugs. All what we did, we switched to another statin at a lower dose, and we gave him control. We kind of asked him to build it up himself. 5 milligrams daily. If he gets no symptoms after a week, he can increase it to 10 milligrams daily. If he gets no symptoms, then increase it 20 milligrams daily. And we reviewed him in 3 months. 3 months, he came to see us. He liked the 10 milligrams, and he said he's stable on that. And basically, his results were as follows. His LDL came down nicely, 66% reduction. And it's very important to also remember that statin response, these figures that we get, 55% reduction, 50% reduction we're likely to get from statins, it is dependent on many factors, but also don't forget these are averages. So when we say atorvastatin 8 is going to give you 55% reduction of LDL cholesterol, that's an average, meaning that some patients will get less, some patients will get more. And that differs on the whole lipid pathway in the individual, how people metabolizing their lipids, what kind of recycling they have, what kind of absorption cholesterol they have, because we know everybody handles it slightly differently. So what I'm saying is that don't always assume that the figure is going to be accurate. So not everybody's going to get 50% or 60%. It could be less, could be more. In this case, this patient was very easy, straightforward case. We just put him in different statin, lower dose, build it up, and it worked, and he was well controlled. Yeah. This is an interesting case. This is a patient who is 67 years old. He had an NSTEMI, had PCI, he had a dilated aortic root, well-established coronary heart disease. Sorry, I'm going into case 2, assuming there was no questions on case 1. If there are, let me know, Evan. I can't see questions. So DVT, that's his baseline cholesterol, 4.2. He's got NSTEMI, he's got dilated aortic root, and he tried 3 statins previously: atorvastatin, simvastatin, pravastatin, muscle aches and pains and feeling of sickness with all 3. So he was adamant. So we actually thought we're going to go down the route of PCSK9 inhibitors with him. He does qualify. We asked him, okay, so what would you like us to do? Would you like us to give you an injection? Because we thought, you know what, he doesn't want to try anything. So, but it's interesting, he wasn't actually refusing the idea of tablets. To the contrary, he did not want injections because he had fear of injections. So I said, okay, well, let's try. So we've given him 10 milligrams once a week of rosuvastatin, just see how he gets on. He didn't tolerate it very well. had muscle pains and aches. We offered him again injectable. He didn't want to. So we thought, you know what? His LDL is so high and his risk is so high, we were trying our best. So we've given him 5 milligrams of rosuvastatin with ezetimibe, just see what he gets in with it. He had a rash with ezetimibe. So we stopped that. We re-offered him an injectable. He declined again. So I said, okay, well, and clearly rosuvastatin didn't work for him. So there was no point of just retrying that. So we established that the pravastatin testing that he had before probably wasn't convincing. So we thought, you know what, let's try something different. Rosuvastatin, pravastatin, which is a weak statin, but with ezetimibe. I know he had a rash, but we couldn't establish if that rash was genuinely due to ezetimibe. And, we asked him to describe it. Is it on the day? It didn't tally. The rash he had, it was before even he swallowed his ezetimibe tablet. And that's why it was very important to establish the timeline. And we're very keen usually when we speak to our patients to ask them to keep a diary. What symptoms you're having when? It does help because then we can ask them, well, you had your ezetimibe on a Friday, but you're reporting the rash on a Wednesday. So it's like, it could have not been. You haven't even taken the thing. So we didn't think that ezetimibe was the cause of the rash based on the patient description. So we give that a try. I think he knew that we are coming towards the end of tablets as well. We were kind of getting limited. At that time, there was no bempedoic acid, by the way, so we couldn't offer that. And it worked. His LDL has come down to 1.9. We had a good 58% reduction, and he tolerated it well. And he worked on his lifestyle, and he lost a little bit of weight, healthier. I think what he was a bit of a tricky one. I can see we've seen him multiple times in the clinic, and I think we needed to build rapport with him and win his trust. And it's interesting when you first see the patient and there isn't as much trust, they seem to be more sensitive to everything that you give them. But as you get to know them and they trust that you're there to support them and you're not dismissing any of their side effects, they seem to be more reasonable in actually accepting or not if the side effects that they're reporting is or isn't related to the actual tablets that they're having. So this is an example of a second case, if you like, where we had to navigate something a little bit more, build rapport and deal with that. So case 3 I have for you, and then I'll be concluding 4 questions. So in this case, 61 years old patient with had a severe history of cardiovascular disease, he wasn't on any lipid lowering therapy. His LDL was 2.6 baseline. He wouldn't want to try statins because he had severe cramps and joint pain with pravastatin, simvastatin, atorvastatin. Of course, target LDL for him was less than 1.8. If it's not, then less than probably 1.4. Previous LDL results were 2.9. We do look at historic LDL readings in order to potentially explore if they would qualify for therapies such as PCSK9 inhibitors or inclisiran based on a trend. The reason is because a single LDL reading may be misguiding sometimes. And therefore, if we look at trend and somebody's constantly was reporting 3, 3.1, 3.8, sorry, 2.8, 2.9, and suddenly one time he gets a reading of, I don't know, 2.5, we don't just dismiss that. Dismiss the use of injectables on that basis. We actually do take into account what were the previous reading, and potentially we can recheck the LDL as well. So it needs a little bit of a clinical judgment there. In his case, he was just adamant. He wouldn't take statin. And I brought this as a case just to show that sometimes the patient just doesn't want to take a statin and there is nothing we could do. We offered him rosuvastatin, we offered him, he didn't want to try anything. And we agreed to him in his case to just try aliricumab. I know he was below the actual threshold slightly in this case. Inclisiran wasn't available at that time when we were offering this. He was somebody who was got very high risk with multiple admissions, and we had to justify it clinically as an exception. There might be some cases which you come across are like that. The good news for him, he tolerated it well, he was stable on it, and his LDL came down nicely. And in August 2021, his LDL was 1.3, and he continued on it, and our 12-month review for him was absolutely fine. By just giving you about what we seem to be up against. So in this case, of course, this patient had a very good level of reduction of 50%. Of course, nowadays with inclisiran, probably can offer him that. This is just a snippet of a review of patients referred to us with statin intolerance. This is a presentation that my colleague presented at ESC Congress. So over 6 months, we had 207 patients referred to us who were reviewed with labeled as statin intolerant. 73% of them were actually labeled as statin intolerant. You can see here what kind of symptoms they've been reporting. 53% was musculoskeletal, 8% was deranged LFT, 7% was fatigue, 14% was GI, and you've got some kind of psychiatric reasons, etc. And what is interesting, we kind of offered to patients, only about 50% of them wanted to re-challenge. They tended to accept a re-challenge if they didn't qualify for an injectable, which is quite interesting. So there was clear bias where if they qualify for an injectable, they're less likely to accept a re-challenge. If they don't qualify for injectable, they accept a re-challenge. What is interesting is that nearly 65% of those who accepted a re-challenge were restarted on a statin. And those who didn't accept a re-challenge, it's either because they had a really severe musculoskeletal symptoms before and that were tried on multiple statins, or they qualified for PCSK9 inhibitors. So as you can see, 80% of them qualified for PCSK9 inhibitors and 70% had severe musculoskeletal symptoms. Therefore, they did not like the idea of trying a statin anymore. This is the kind of regimens that most patients ended up on. Of course, the majority we already introduced on rosuvastatin, weekly, daily, 10 daily, other kind of alternate day dosing. Others were reintroduced on atorvastatin, pravastatin. We had very few on fluvastatin, simvastatin, but mainly rosuvastatin was the one that we used most. To conclude, and then we've got probably 5 minutes for questions. Statin intolerance is definitely exaggerated based on our experience, but it cannot be dismissed. And you can't just ignore what the patient telling you. I had patients who come and told me they've got muscle symptoms. I always check vitamin D levels, and they indeed had muscle symptoms, but it wasn't due to statins, it was due to vitamin D deficiency. Correcting vitamin D deficiency corrected their muscle symptoms, and therefore, thereafter, they took their statins with no problem. So work with the patient to establish what could be causing those symptoms. So using a person-centered approach, it is possible to re-establish many patients, but not all of them. In our clinic, we'll probably re-establish about 60 to 70%, but the others we can't, either because they completely reject it or they need to move on to alternative therapies. Using different statins, weekly dosing, alternate day dosing works, and using combination therapy probably is best to reduce effects, but also to achieve targets and meet that. I hope that give you a little bit of more comfort in handling statin intolerance in your practice. We've got probably about 5 minutes for questions. If you have any, I'll be happy to take them.
Thank you very much, Dr. Khatib. I think that was very, very informative. And I think you must have sort of really mesmerized people because we've not got any questions, which is brilliant.
There is one.
There is one that's just come through from Mamuna. Actually, there's two questions. One was from Ilse asking whether PCSK9s can be prescribed in primary care or whether they've got to be referred. I think in answer to that, because I understand, you know, we've got people sort of logged in from different parts of Yorkshire and Humber, so it will very much depend on the traffic light status of those medicines in your area, so please try to find out. And then there is a question as well from Mamuna about lipid optimization. If a patient is on a 2/80 plus ezetimibe, but levels are not to target, but the LDL cholesterol is 2.4, so not eligible for injectables, would you switch to rosuvastatin or what would you do?
Just the first question, Eben, that you answered. We know from national data when we look into PCSK9 monoclonals that the majority of the services are in secondary care. However, there are hubs where are using it in primary care. So as Eben said, do check what's locally you've got available and you can go for that. The answer to that question that you've got, I'd need to know more about the patient and how far have we come from their baseline. If this patient is very high risk and then we're aiming for an LDL of less than 1.8 or less than 1.4, then I'll probably be tempted to look at their baseline history and potentially consider them for inclisiran because I know I'd look what happened before they were on ezetimibe potentially. There might be a case if they're very high risk. Switching to rosuvastatin is a valid strategy, but from my experience, mind you, the patient could behave differently. From my experience, probably it might give you some further reduction, but I'm not sure how far we are from how well they responded to the atova and ezetimibe. So there is a way of tackling this by thinking about what their baseline risk, what was the level of reduction they've achieved, and what would they obtain from intensifying their therapy. And are there any other lipid lowering or other like risk modifying or residual risk that we could tackle in this patient in specific? But would I actually base it purely on one LDL reading and dismiss the introducing of initial therapy? The answer is no. But I can't give you this specific case. I'll have to look at the detail.
Excellent. And the next question is really very much like it. Majid is just asking, I have a patient on bempedoic acid and ezetimibe, still not to target. What do I do next? And I think, again, it's obviously going to need more information about this specific patient and the level of risk and the scenario surrounding that.
And if they are primary or secondary prevention, of course.
Of course. I'm sure you won't necessarily welcome all the people on this call contacting you for advice. That might be...
That's no problem.
But I think if you want to contact your, any cardiovascular disease leads in your area, where, might be able to provide some support on the clinic, or the lipid clinic might be able to provide some advice and guidance on how to manage any specific patients. But I think this has obviously been a very, very informative session. I'm sure a lot of people are sort of aching to ask you what to do next, Dr. Khatib. So I won't be surprised if we have you, with us again very soon, if you, or, if the timing does allow. And Helen, I'll let you sort of talk us out of the session.
Thank you, Evan. Just to mention, there was another question in the chat about the traffic light system and doing biologics in primary care, and just wondering whether there was any primary care prescribing examples that could be shared. I don't know if you want to take that outside of the meeting, Evan, and so that you could provide that. So that, I think it's in the chat. Have a look. It was from Ola.
We found it. If we can. If we can sort of get pockets of examples that people are willing to share, then we can definitely do that. But yeah, they are monoclonal antibodies, but they're quite different because they're not like the same. Well, they're a bit different from the way we view biologics that we use in rheumatology and gastroenterology. But yes, they are monoclonal antibodies, just like those other medicines too. Again, you just need to look at the traffic light status in your area to know how they're currently being used. But watch this space; they could very well be used differently in the future.
Okay, thank you. Obviously, it covered a lot in the session. We had a few questions whether you'd be able to share your slides at all, Dr. Khatib. Would that be okay?
Yeah, if people email you, then we'll take it from there.
Okay, that's lovely. Thank you. So we put a little feedback form into the chat for anybody. We love getting feedback on the session so that we know, are we addressing the needs that there are out there? Is there anything that we're not addressing? And we've also just put details in of the next session, which is on the 14th of November. And we're just starting to advertise that. So hopefully do come along. That one is on secondary causes of hyperlipidemia. So we look forward to seeing you in the future. Other than that, I'd just love to thank Eben and Dr. Khatib. Thank you so much for a really informative session. Ooh, I've just had a quick question, exceptionally informative. Unfortunately, PCSK9 and BEPA are very limited or not available in Ireland. So options are limited. We are reaching far and wide with our update sessions. So thank you everybody for joining us. I'll draw an end to the session now, and thanks very much. Bye-bye.
Thank you. Thanks.